Well, good morning or good afternoon, everybody. Thank you for joining us for this AGA webinar on exploring bundled payment models for colonoscopy. We're at the top of the hour right now. We're going to wait for about 1 more minute to allow other folks to come on the call, and we will get started. For those of you who aren't familiar with my voice, I am not Jimmy Kimmel, nor am I Jimmy Fallon. I'm Joel Brill, gastroenterologist. I sit on the AGA Institute's Practice Management Economics Committee, and I've had the pleasure of being the lead author on the AGA paper, which was published in Gastroenterology in March, which describes AGA's bundled payment framework for colonoscopy being performed for colorectal cancer screening or surveillance. Along with my other authors, I'm privileged to help develop this on behalf of the gastroenterology community. And today I'm joined by my colleague, Dr. Charles Accurso. Charlie is the president of the Digestive HealthCare Center in Hillsborough, New Jersey, and he will be discussing his experiences and expertise with implementing a bundled payment during this webinar. During the webinar, we will review what is a bundled payment. We'll address why the AGA chose to start with colonoscopy, and we'll also review how bundles are defined and implemented. Dr. Accurso will then discuss his experience with negotiating bundled payments for colonoscopy with 2 of the payors in his region. Now, here's kind of the key thing. If you've got a question, please feel free to type your question in the question pane on the GoToWebinar screen. We'll do our best to answer the questions at the end of the webinar. And if there are questions that we don't get to, or if we need to do further research, we will certainly follow up with you at the end of the webinar. So with that, let's kind of get started. Amy, if you'd be kind enough, there you go, great. So as mentioned, we're going to discuss today a bundled payment framework for colonoscopy, which is being performed for colorectal cancer screening or surveillance. And as mentioned, I'm Joel Brill. I'm a gastroenterologist in Phoenix, and here we go. What's a bundled payment? Bundled payments are single payments, and they can be for a condition such as diabetes or heart failure, or for treatment, for example, hip surgery or cardiac catheterization or the like. A bundled payment covers a predefined set of services across multiple providers and multiple settings. So that might mean that, for example, the physician, the anesthesiologist, the radiologist, the pathologist, and services that, for example, might take place in the hospital, outside of the hospital, in a laboratory, in an office, and the like. A bundled payment aims to improve the value of healthcare by controlling costs, improving collaboration amongst providers, trying to eliminate unnecessary services, and improving patient outcomes through reducing the incidence of complications. Next, please. Now, our current system, as we've seen from lots of these beltway pundits and people who profess to know everything there is to know about healthcare reform, we're trying to reduce fragmented care. Medicare and many commercial payers make separate payments to healthcare professionals and other providers such as ASCs and labs and hospitals for the services that they furnish to beneficiaries for a single illness or procedure. One of the problems is that there's minimal coordination across settings and across professionals. Payment is based on how much you do, not how well you do it or was it appropriate to do it. And obviously it create some scenarios because it doesn't really address how well the healthcare professional does in treating the patient. Several years ago, Medicare, as part of its reform initiative, initiated a bundled payment for care improvement initiative. And in that, Medicare proposes to link payments for multiple services that a patient receives during an episode of care. Next, please. Now, many of you have seen this. This was Dr. Elizabeth Rosenthal's article in the New York Times on June the 1st of last year. And Dr. Rosenthal describes cost variation in colonoscopy. It raises the question, why would the cost of a colonoscopy be over $8,500 in the Upper East Side of Manhattan? Why would the West Coast have payment rates anywhere from $5,500 in LA to $4,100 in Seattle? Why would Miami be $4,500? Why would Baltimore be $1,900 or Nashville be $2,100? Now, as many of you know, the 3 GI societies have initiated an effort over the past year to educate the public about the true cost of colonoscopy. And as those of you in the call also know, the gastroenterologist actually gets a very small amount. In fact, the Medicare payment for a screening colonoscopy in most parts of the country ranges between $200 and about $230. So clearly there's a lot of other money from other services that is going into this, quote, the cost of colonoscopy. That can include things such as where you do the services, did you provide the service in a hospital, in your ASC, in your office, did you use an anesthesia professional, what type of prep did you use, did you obtain biopsies, and the like. And that seems to lead to a lot of variation, but the important thing is to educate people that, frankly, what we as gastroenterologists are receiving isn't really $8,500. Next, please. So the AGA's Practice Management Economics Committee convened a subgroup of practicing physicians from communities across the country. And we looked at, what would be a good topic for gastroenterology to choose as a bundled payment. And the panel basically selected colonoscopy, more specifically screening colonoscopies. Well, why colonoscopy? There's pretty much a very clear beginning and an end of an episode. I mean, let's face it, unlike diabetes or heart failure where the patients can be treated for months, if not years, colonoscopy has this, clear set of services that allows us to identify a fairly predictable range of services. It helps to limit variability in costs for both payers and providers. And in simple English, what that means is that if you've got your data, you should be able to negotiate a payment for a colonoscopy bundle as opposed to the complexities, for example, with diabetes or COPD or the like. And colonoscopy obviously offers opportunities for quality improvement and cost inflection. Many of us have seen articles, for example, one that addressed the question as to whether patients were returning for follow-up colonoscopy at inappropriate intervals and the like. We've also seen questions raised in recent years about what we do, and certainly, the release of data by Medicare about a week ago's time as to what physicians charge, what physicians get paid, if anything, has created some confusion. So colonoscopy really offers opportunity to identify high-quality care at a cost-efficient amount, negotiating with payors, with purchasers like self-funded employer groups, and the key thing is the potential of a financial upside for physicians, and also as part of the bundle to get paid for services that traditionally Medicare and other payers might not have paid for, such as the pre-procedure E&M visit. Next, please. Now, why is cost-efficient care important? Well, as most of us know who have ASCs, we can usually provide services for patients in an ASC at a cost that's much more effective and efficient than providing it in the hospital outpatient department. Questions have been raised in some communities as to whether the anesthesiologist needs to be present for all procedures or just for patients with high-risk conditions. And we've seen articles, for example, published by RAND and others who have looked at the variation across the country. Currently, we get compensated, if you think about it, for a repeat colonoscopy due to poor prep. And as those of you recall are aware, the gastroenterology societies have been involved in a now over 2-year process of reviewing all of the endoscopy codes, bringing both upper and lower endoscopy through the CPT panel, and then going through surveys for evaluation. And one of the questions that has been raised is whether colonoscopies are complete and how a complete colonoscopy or an incomplete colonoscopy would be reported. So clearly, if you're doing a colonoscopy and the prep is inadequate and you have to bring the patient back, there are some people who have raised the question, is that, in the patient's best interest or not? So cost-efficient care and a bundled payment means that we're being held accountable for providing high-quality prep and also performing complete examinations. Do it right the first time. I've addressed the fact that many of us saw the articles about 4 or 5 years ago's time, which looked about Medicare patients returning for surveillance colonoscopies at intervals that weren't the ones that were recommended by the multi-society task force of the 3 GI societies and other interested societies. So following quality recommendations, following our multi-society recommendations is a selling point, obviously, to the payer and purchaser community. And many of us have seen the report from the GAO last year, which asked the question about physicians, gastroenterologists, urology, and dermatology, and other specialties who have incorporated in-office labs and things of that nature. And so questions have been raised, and so one of the things that can be addressed is that a bundle could be used to demonstrate to the public and others that we're obtaining pathology specimens when they're clinically indicated and appropriate. Next, please. So, as mentioned, a team of physicians representing practices in a variety of communities, West Coast, Central, East Coast, practicing physicians work to develop the content and the carve-outs of a screening colonoscopy bundle. And our goal was not to price this. Our goal was to basically provide a framework where the gastroenterologist could use to identify his or her costs and risks when you're contracting for a bundled payment. Next, please. So the bundle is defined as basically these 3 key buckets: as a screening service for an asymptomatic patient who's undergoing colorectal cancer screening. Now, as many of us are aware, that service is considered to be a preventive service under the Affordable Care Act, which means that the patient doesn't have any financial cost share or financial responsibility. But one of the problems that has also occurred as a result of the ACA is that if a patient goes to see a primary care physician and has some other screening test performed, such as a FIT or an FOBT or a FLEX-SIG, and they're found to have an abnormality, the patient gets referred to us in order to undergo colonoscopy. But that's no longer considered by Medicare or by some payors to be a screening service. It's now considered to be a diagnostic service. And the problem is that at that point, that patient now has a financial responsibility, no different than, for example, the patient is found to have occult blood and referred to us for a colonoscopy for evaluation. So we felt that, as you'll see, that a bundled payment can help address that and may also provide a mechanism to contract with payers in order to address that, in order to reduce the barriers for patients to get colonoscopy and the colorectal cancer screening services that they need. And then, as we've mentioned also, both of these lead into surveillance services. So for a patient who's had a previous colonoscopy for CRC screening and now is returning for a follow-up procedure, when should those procedures be performed? And As many of you are aware, in September of 2012, the Multi-Society Task Force published updated recommendations regarding surveillance intervals. Next, please. So whenever you define something, you also have to define the exclusions. And we certainly don't want us, our colleagues, or the like, to be responsible for things that are outside of our control. So one of the first things we said was that by developing a bundle in this framework in this manner, we're avoiding hospitalizations. The second thing that we're avoiding from a risk standpoint are patients who are undergoing therapeutic colonoscopy procedures, such as control of active bleeding, placement of stent, performance of an EUS, decompression of a volvulus, lesion ablation, removal of a foreign body, dilation, and the like. You'd want to not do this, at least in our recommendations, with a contract for a bundle in your pediatric population, because it's probably a different set of risks and the like. And we also felt that certain asymptomatic patients with certain pre-malignant conditions probably at this point should be excluded from your contract negotiations, such as patients with FAP, Lynch syndrome, patients with extensive inflammatory bowel disease who are requiring 4-quadrant biopsies every 10 centimeters, or other defined high-risk conditions. Again, the AGA goal is not to tell you what a bundle should be priced at. It's simply to provide you with a framework of thinking about how to negotiate for what should be included and what should be excluded. Next, please. So there's 3 parts to a bundle. There's the pre-procedure evaluation, and in that, the evaluation, the E&M visit, the prep, the instructions to the patient. Does that patient need any antibiotics? Do they have any medications they're taking that need to be discontinued or adjusted? And in some instances, the need for laboratory tests. Next, please. The date of service. The date of service is obviously your professional fee for performing the colonoscopy, the facility fee, the sedation fee, and the pathology fee. And next, please, the post-procedure services. Next. The post-procedure interval would include the need for an office visit and E&M follow-up if you felt it was necessary. The physicians who worked on this felt that a repeat colonoscopy that was due to poor prep should be included within the post-procedure interval, and that they really didn't establish a time frame, saying for 1 week or 1 month, but basically established that time frame would be 1 year of the procedure. They also said an incomplete procedure, if for whatever technical reasons you can't get to the cecum, you have to think about what would you do differently. Would you bring that patient back a second time, or would you perform some other alternative imaging or diagnostic service in order to assure the patient and the referred physician that the patient had a complete colorectal examination. And then also post-polypectomy bleeding. And that was felt to have a time frame of 7 days time based on literature review and data showing when the majority of post-polypectomy bleeding complications occur. And as we've mentioned, in this post-procedure interval, you have to ask the question that couldn't get to the cecum in the first place, what type of alternative technology might you consider, and how would you factor that in into calculating what you would want to try to negotiate for as a payment for a bundled payment for colonoscopy. Next, please. So kind of graphically, you can kind of see how a bundle frames out through the pre-op, the colonoscopy, and the post-procedure period. Next, please. So the next step, of course, was to take a look at data, because we had to provide a framework for our colleagues as to what types of services should be included and what types of diagnoses, what should and should not be included. We spoke to a number of national payors, and actually one of them, Humana, graciously provided us with data from both their commercial and their Medicare Advantage business lines. And they allowed us to analyze the data to identify the frequency and nature of post-procedure visits. So in the paper that's published in March, there's actually an addendum which contains a list of ICD-9 and ICD-10 diagnosis codes that you could use. We've provided those that you would use to include or exclude from your bundled payment depending on the relevancy to the procedure. So, for example, if the patient was seen in the emergency room for muscle weakness after the procedure, it's probably not related to the colonoscopy, whereas if the patient had abdominal pain or bleeding post-polypectomy, I think all of us would agree that that would be a post-procedure service that would be part of the bundle. Next, please. So what a bundled payment does is it helps to align patient expectations, as we mentioned, about the waiver of cost share for preventive services. This is something that can be, we believe, can be negotiated with payors and reduce barriers for patients undergoing colonoscopy as part of their colorectal cancer screening services. Obviously, aligning all of our efforts, we're professionals to perform services that are at the highest quality, cost-effective, and patient and person-centered, and the like. Next, please. Transparency is obviously a big buzzword in today's healthcare lexicon, so a bundled payment can support initiatives that you can choose to do at your own practice level. For example, measuring rates of your completeness of examination, adequacy of prep, adenoma detection rate, and complications, which require post-procedure follow-up. These are things that are captured, for example, in registry reporting initiatives, in recognition reporting initiatives, in National Quality Forum, PQRS, and the like. So it's consistent, kind of reinforcing what you're being asked to measure. And that the AGA has developed a Digestive Health Recognition Program module in conjunction with Bridges to Excellence that would allow us to report on these measures and obtain Bridges to Excellence recognition and to benchmark your data. And in looking recently, we've noted that more and more payors are utilizing Bridges to Excellence in a similar way that they're using, for example, completion of MOC modules and like in terms of their physician negotiation and network programs. Next, please. So, as mentioned, we referred to the Multi-Society Task Force recommendations. Dave Lieberman is the lead author of that, in case you haven't seen those, but this is sort of a graphic recommendation of what this represents. And as you can see, that the follow-up surveillance intervals depend on what was the pathology, what were the size of the lesions, how many lesions were found, and the like, and whether adenomas were high risk or low risk. And it's fair to say that within the coming year's time, this may be reflected in some adjustments to some of these quality measurement programs. Next, please. So implementation strategies, obviously, time payments to quality outcomes and efficiency leads to, how do I get paid? And there are two options. One is to negotiate a prospective payment, so the amount comes to you as the physician, and then you distribute the payment to your AFC, to your anesthesia professional, to your pathologist, and the like. A second model is a retrospective contract, where each practice receives fee-for-service payments, and then there's a retrospective, sort of like a true-up period, and distribution of savings if quality and cost targets are met. I think Charlie will address those various opportunities in a few moments' time. Next, please. So if you're going to do something of this nature and get started, some thoughts. We have a saying around the office: crawl, walk, and run. Negotiating a contract with dual risk, upside and downside risk. If you haven't been in a risk contract before, might not be the wisest thing. You may wish to start with negotiating a contract with upside risk only as a starting point. You need to look at your patients and your population risk, how many of your patients are being seen in an urgent care center or an ER after a procedure, what's your hospital admission rate. Statistically, we know it's small, but are you, what is your rate compared to the population? What's your percentage of repeat colonoscopies due to poor prep? What's your percentage of procedures that don't reach the cecum? How many of your patients require surgical procedures afterwards and not for cancer or the like? And also you might want to look at the question of medication utilization after procedure. Next, please. This is the paper that we referred to, and as you can see, here are the authors representing practices from number of settings across the country. Next. I think at that point I'm going to turn it over to my colleague, and Dr. Accurso, if you care enough to take it away.
Thank you, Joel. That was excellent. I appreciate the time and effort that's taken to put this information together. Hello, everyone. I'm usually on your side of the phone, but I was honored to be on this side, and I'll try to do as good a job as Joel did in this presentation. My hope is that how we take this information in the paper and what Joel has just talked about, how can it be implemented in a private practice setting. Next. So I represent the 6-member GI group. We practice bread and butter gastroenterology. Over the years, we've grown to employ our own anesthesiologist. We own our pathology lab. We own our own ASC, and we have all the bells and whistles of a typical gastroenterology practice, and we're right in the middle of the state. Next slide. We have a challenging practice environment. We're part of our large ACO called Optimus. We attend at one hospital, but that may change because our main hospital was recently aligned with a university hospital. So we're not sure where that's going to go. And some of our top referring physicians that we've had long-standing decades of relationship with have been aligned or have been bought from another competing hospital. So we're being kind of torn apart, and there's plenty of competition. Next slide. In thinking about what's to come, we think that we're going to continue to get Medicare reimbursement, decrease in Medicare reimbursement. We've been unable to negotiate higher fee-for-service rates with our commercial payors, even if they pick up the phone when we call. As I suggested previously, we expect that because of the disruption in our current marketplace, there's going to be changes in referral patterns. And obviously, let's not forget that the patients are becoming much more price conscious, especially with the high deductible plans. We think that, next slide. So why do we go towards a colonoscopy bundle? There's downward pressure on fee-for-service, as we just described. These types of contracts allow for potential increase in income if the costs are contained and there's some dollars to split with the payer. We use this method to continue to be recognized as high-quality, cost-efficient practice to our referring physicians and to our patients. It does lead, once you start down this path, and this is really a step on a long road, on a long journey. It's not, the end. So it does lead to opportunity to develop other models, and through a halo effect, hopefully we can continue to improve cost and quality and manage other conditions that have a potential higher reimbursement. Next slide. Next slide. Thank you. As you will see from what I will describe to you, our contracts are slightly different than what Joel spoke about. The paper wasn't available when we negotiated these contracts, but I have to tell you that that is a really great way to start. So we are engaged in 2 bundle payments for colonoscopy with 2 separate payers. We have included all types of colonoscopy procedures. You know, as I said before, our bread and butter is screening colonoscopy, outpatient colonoscopy. At least in our practice, it's rare to see complicated strictures, etc., and those we would do in a hospital setting, which is specifically excluded from the contract. The contracts include services performed on the day of colonoscopy, pre-colonoscopy, post-colonoscopy, as was described earlier. Next slide. So our first contract is a prospective bundle contract with a small payer in a tri-state area. It bills for a contracted pre-established bundle price. So on the one price, we have included the office consultation if necessary, the prep, the professional fee, the AC facility fee, the pathology, anesthesia, and any follow-up and post-colonoscopy complication within a 21-day period. Next slide. In the retrospective model, this has some of the same, some of this information is somewhat repetitive to what Joel had presented, but again, we negotiated this is a little bit different in that the bundle price is based on our practice prior 2 years retrospective analysis of the costs. Now, most small practices like ours do not have this data. The data really comes from the payer, and this is probably one of the most important topics here, is that there has to be a reevaluation of the relationship between us physicians and the payers, in the sense that previously we've had some adversarial type relationships. We can't do these kind of contracts unless we develop a cooperative, forward-looking relationship with the payers, and that's what's happened with us, and they really have stepped up. But it is new to them too, so you have to make have some leniency in that respect. So the practice continues to, and this is the other big important point, we continue to receive the fee-for-service payments that we currently do. So we're not taking initially any downside risk. This is our first contract this way. We're not prepared, both psychologically and infrastructure, to take downside risk, and the payer was smart enough not to put us in that position. It's really an upside-only contract. And every quarter we retrospectively look at the data with the payer and calculate if there's been any gain sharing. The important part of these 2 contracts is that we included for the first time, we don't have any of this in any of the other contracts we have in the practice, quality targets, especially patient satisfaction surveys, the adenoma detection rate, and the fecal intubation rate as quality measures. Next slide. So again, the colonoscopy is the triggering event, and in it includes all the things that are listed on the slide. This is a 30-day post-procedure period. The important thing about this is so new that we're still negotiating, and it's new to the payer, that we're still negotiating what to include in the 30-day post-colonoscopy in terms of potentially avoidable complications. So more to follow. Next slide. So, as I said, we're not assuming any downside financial risk. It's only upside. Important part, and I think this is really critical, we, at least initially, do not take a price cut. The payer, as I said, was smart enough to say, look, let's go forward and see if we can cut the cost of colonoscopy going forward for the patients. And again, here the financial incentives are aligned with those of the payer and the practice, but they're also aligned with those of the patients and the ACOs. Next slide, please. Uh, these negotiations took quite a while, and you should be ready to present patient satisfaction data and quality data. You should be able to get that information both internally as well as by starting to report your data to the national, to the AGA, to the AGA. The important thing about these payers is that not all prepared to go forward. So you have to work with what is in their current system. So have some leniency, some flexibility, implement what they can implement. And again, the trust that I noted before, take the opportunity to develop these relationships. Next slide. So it is possible to negotiate a bundle contract that does not include a price cut. It does require lots of time, strong billing systems, and staff. It does change the internal flow of the practice in terms of how you account for the payments. It is time-consuming. This is I put this in because many practices should consider paying a physician to do this. Although it may be difficult to align the providers and distribute the payment if the practice is not tightly affiliated with other professionals, this is the opportunity for us to lead. So we gastroenterologists should lead this effort. As Joel once told me, the person who invites people to the dinner table gets to choose where they sit. So the ACO, our ACO has really jumped on this. We're trying to be the first ACO, or one of the first to extend this to other specialties. It aligns the financial incentive of the physicians in the ACO, the primary care physicians especially, the specialists, us in this respect, and eventually even the hospital. Next slide. So in closing, stay involved. This has led to the opportunity. The financial incentives, let's be honest about it, do drive behavior. So let's turn that to our advantage and to the advantage of our patients. Bundle payments allow us to take care of ourselves as well as our patients. And not everything has been worked out. Jump in, use Joel's paper, and more importantly, let's lead the fight. Let's become directors of care and not just providers. I left you with a reading list on my next slide that will probably bring you as close to the most important knowledge on this. So I hope this has helped you. Thank you.
Charlie, thank you very, very, very much for sharing your thoughts, because I think that it's really key for our colleagues to be able to learn from thought leaders like yourself who have, jumped into the pool and gotten wet and, making this, as you say, making this work for all. So I think at this point we've got a few moments to take some questions. If you have a question, type it into the question pane, and it will be answered in turn. As we've mentioned, if we can't get to all of the questions, we will post a Q&A online. And with that, it looks like at least there's a question or two. So, Amy, could you lead us off?
Sure, thank you. The first question is, what markets are moving in the direction of bundled payments right now and why? And what accounts for markets that are not moving in this direction?
Charlie, you probably ground zero, you saw the need, or you had, you saw it coming in New Jersey, right?
So we were the first practice to do this with in this area, and then it's expanded, I believe, about 30 other gastroenterologists. Certainly, I think we physicians have to push the envelope with the payors on this. I mean, it's the best benefit of our patients and ourselves, and I think it moves us away from the fee-for-service to a fee for patient satisfaction, quality, and outcomes, and it's good. in the reason I got here in this conference is I made some calls from around to the AGA, and there's not very many that people around the country doing these kind of contracts. Now it's been done, I have to say, in other venues, big organizations across the country, even Medicare, but in a small practice setting, we haven't really seen it.
So part of it also is that, you know, some of the people who were involved in the development of the paper have seen it happen. For example, Scott Tedover, who many of you on this call know, is the president and CEO of Minnesota Gastroenterology. Minjee's developed a bundle. Payor up at University GI up in Providence, Rhode Island. A little bit of a different situation because they had two major payors and also a very large hospital-dominated system, but they saw an opportunity to pursue this. I'd say that probably the more rural the area is, or the less impacted that any type of managed care or payment reform seems to be, there's probably less of an interest. But then again, you start looking at things such as Walmart, which is basically negotiated one-price-fits-all contracts for their employees with some specialized centers around the country for orthopedic and cardiology programs. And Lowe's, out in Charlotte, North Carolina, has been, been involved in flying, all of their associates up to the Cleveland Clinic for cardiac surgery. So, it's market-driven, and I think that probably if you ask the question, you might be surprised to find that there's interest, and the interest may actually be coming from the self-funded employers, the people who are financially on the hook for the care for their employees and dependents and the like. Amy, next question.
Thank you. The next question is, in a bundled payment that includes facility, pathology, professional, and anesthesiology fees, perhaps with each tied to separate companies of various owners, what's the most cost-effective way to allocate the single payment received to the various entities?
Oh, gosh. Probably there needs to be a convener, and ideally, I think you've heard from, Dr. Accurso and myself, that, probably the gastroenterologist is going to be the convener, although theoretically it could be the hospital, the ASC, or someone else as the convener. So whoever, is the convener then needs to discuss how the contract or arrangements are going to be with, the facility, with the anesthesiologist and the pathologist and the like, whether they're contracted entities or whether they're entities that are, under the practice's control. And it's a straightforward contractual relationship. Charlie, anything else to add?
No, I think you covered it well. In our case, it was a little simpler because of our current organization, but it's exactly as you say. I do think that we gastroenterologists though have to lead the fight if we can. I mean, it's in our interest, since we're talking about colonoscopy, to do so. But this goes back to the issue of requiring time and effort on the physician side, because just signing the contract doesn't really end the process, and as you just described. But it can be done. I mean, the push should be that not doing it is not an option, and it can be done. And we're not going to tell you all the. I can speak from my own experiences, but the question raises a whole bunch of other questions that are applicable in another type of bundle for, let's say, another disease process. So let's do it. But we'll just have to kind of model ourselves through a little bit.
Great. Amy, is there another question?
Yes, there is. And this one is probably best answered to start by Dr. Accurso. Why did your practice decide to participate in an upside-only model first? Are you planning on eventually transitioning to a two-sided model in which you assume both upside and downside risk?
The main reason is because we have no experience with risk contracts, and really that's what those two contracts are the ones that were presented to us, so to speak. We made a lot of, we pushed the two payors quite a lot to come up with a plan. We initially had sent them a proposal 3 years ago to the payer with the retrospective contract. We made lots of calls to the other payer, and eventually they responded. I think the train on this bundle contracts has left the station, so I think people kind of, and payers are coming around to it. But the main reason really in terms of the risk is that there's, and in terms of selling it to other physicians in my practice, is that there's no downside risk. We're really going to get paid for doing the right thing at the right time on the quality measures. And as we learn, I expect as we learn in a number of years that we may want to transition into a downside risk. But that's not what the payers are willing to do at this time.
Thank you. There have been a couple of questions that have come through. People are interested in hearing how the negotiation of the anesthesia costs have been going.
Joel, do you want to answer that? Do you want me to answer that?
I'll let you take that one first. Sure.
Sure. So again, I think because we already employ our anesthesiologists, we really did not have to have a specific negotiations on this issue. And just trying to be a little speculative here, I would, if I put myself in the position of an anesthesiologist, I would go to the ASC and negotiate a contract, because what really happens in this contract, because especially in the ones that I just described, the anesthesia is already included, and it's a potentially avoidable cost. So we may all go back, if we're appropriately incentivized, to to our own intravenous sedation. I know that's a big issue, and it's not a topic for this discussion. But I think you just have to speak to your colleagues and say, this is what the contracts are being provided, and this is what we can afford, and be fair and honest about it in a win-win. It's possible in negotiations to raise everybody's bottom line rather than hurting someone. So I think go into it with a win-win. I think you'll be successful.
Great. Amy, any other questions?
Yes, we do have a few more. There have also been several questions about what other GI conditions might lend themselves well to a bundled payment model, and what are your thoughts on why?
So I'll take that one. It's kind of two different things. The first is what other GI conditions from an endoscopic perspective, and perhaps looking at GERD and all of the ancillary testing, such as motility or pH, or treatments, anti-reflux, endoscopic anti-reflux procedures, and the like, that might lend itself to a bundle. Some people on the call may also be aware of the work that Larry Kaczynski and his group, the Illinois Gastroenterology Group, are doing around Project Sonar and their bundled payment for inflammatory bowel disease. And Larry's group has actually developed a model which would entail a bundled payment for patients with IBD. It actually looks at pharmaceuticals as well as medical costs, and they started the efforts towards a first year of that pilot, and they also have built a number of clinical decision support tools that would allow that to be implemented in other practices as well. One of the key things in Larry's pilot, which I think is important for all of us to recognize, is that there's a constant effort involved in pinging those patients, making sure that patients are doing well in life. Larry's research showed that people who were contacted on a relatively frequent basis actually were under better control and had probably a less likelihood of showing up in the ER or the urgent care center compared to people who have been in contact. So he's really been at the forefront of this whole issue around consumerism and person-centeredness. And so those types of things I think are going to be very important in the future. What else? I think the sky's the limit. We're only constrained by our imagination.
Thank you.
Any other questions, maybe? Yeah.
Yes, and first I want to reassure all the listeners that we are recording this session and that the direct link to the recording and the questions, and the slides will be emailed to you within the next week, and we'll be including an article on eDigest. There have been a lot of requests. The next question comes in, are there any recommended steps or best practices to ensure that coverage for complications or hospital backup is adequately accounted for in a bundled model?
I think the best practice is run your numbers, figure out how often those things are happening, figure out in the case of a pre-procedure evaluation how often you think it should be happening, and then factor that into your negotiation, for a rate. If the question is how frequently do people have complications after procedures, thankfully the answer, the literature shows that the answer is, less than 1% of the time, and that if you look at the information in the article as to post-procedure inpatient and outpatient ICD-9 diagnoses that can also be used by a practice to help limit its liability and limit its risk in terms of what it might be asked to be responsible for. So as we said earlier, if it's post-polypectomy bleed, that's one thing, but a patient showing up in the ER for a UTI or for a sunburn, 5 days after the procedure, probably we shouldn't be at risk for.
So that's correct. I agree with that. The reality of colonoscopy is that we have very low complication rates. So that's, as Joel just said, the issue of what to include and what not to exclude. My experience has been that you can't write. You can try and think of every possibility, but you really can't. And I think this goes to the relationship with the payer. So in this retrospective model that we've been describing, it's important to have a regular quarterly meeting with the leadership of the payer that's negotiating, so that you can go through these issues. Because our experience is that they're trying to figure it out too. And I think this goes back to the discussion of being honest and fair, in the sense of sharing data between the payer and the practice, and fixing these issues when they come up. I don't think we can predict all the problems that can arise, the majority perhaps, but it's that relationship that's important in my experience.
Thank you. We will be developing a question and answer for the questions that we did not get to today. We probably have time for one final question, and that is, what advice do you have for practices interested in exploring a bundled payment model for colonoscopy?
Don't overcommit. Know your numbers. Recognize that some payers may be further along than others in terms of whether their claims payment system can process a bundled payment, whether manually or electronically. Make sure that you have realistic expectations. I think both of us have said that, you know, incorporating quality and accountability, quality reporting is key. And like anything else, you know, recognize that these can be pilots, and, you know, give yourself plenty of room for mid-course correction, and like don't make the mistake that some of us made, you know, a decade or two ago when we, you know, went full risk for everything, and then patients got admitted to the hospitals because of complications, or we found ourselves paying for surgery or chemotherapy or the like. You know, limit where you are. Start slow and build a foundation that you can expand on in the future. That would be my thoughts. Charlie, would you add anything else?
I would say that we gastroenterologists have an opportunity to push the envelope and migrate from a fee-for-service environment, but it does take us to push our local market sometimes and our payers. So get involved, stay involved in your ACO. If you can't get a live person at the payer, have the ACO intervene, the medical director from the ACO to intervene in terms of opening the door for you and pushing the payer towards these kind of payment systems. And you know, keep it simple. We know colonoscopy. Let's learn what colonoscopy, and then apply what we learned to these other potential opportunities in managing disease or other procedures.
We've had, I should say we, the AGA has had a number of questions from practices around the country around this, and I hopefully the AGA will set up some sort of a collaborative or the like that would allow practices who have an interest to indicate their interest and to kind of share their best practices you know, on these types of efforts. You know, using forums such as the GO conference, DDW, and the like, also will, I think, provide opportunities for people to share what they've learned, what works, what doesn't work. As I think I mentioned at the beginning of this, the AGA's had a lot of conversations with a lot of regional and national payers, gauging their interest and their readiness for change and the like. And please feel free to contact the AGA offline if you have further questions regarding that.
I would like to publicly thank Dr. John Allen and Joel and his co-authors on that paper. It took a lot of time and effort for these colleagues to present this data to you. So on behalf of everyone in the audience, Joel, thank you.
You're welcome. So with that, to my co-presenter and on behalf of everybody, thank you so much for joining us today for the AGA webinar on bundled payment models for colonoscopy. As Amy has mentioned, the recording of the session will be made available on the AGA website in the coming weeks' time. Please continue to read AGA e-Digest for more information about bundled payments and how the AGA is helping you to prepare and during these turbulent times. Thank you again, and have a wonderful day.